Andy, how are you?
Very good, Heidi. Lovely to talk to you.
Good. Thank you so much for taking time out of your busy schedule to speak to us this morning. Now, you're a sports medicine doctor, and can I say you're world renowned for lecturing and treating sports injuries?
I think you can say that, which is very kind of you.
Okay. Now, many of our viewers will be podiatrists, and certainly a lot of the delegates at the Biomechanics Summer School will be as well. And a lot of them will see patients who are runners who present with lower leg pain, probably even more this week after the London Marathon. Now, you'll be talking about a new approach to this, so can you tell me just a little bit about that?
Sure. And look, I think that one of my problems with the whole world of sports injury and sports medicine is that I don't think we question existing diagnoses particularly well, and we definitely don't do it very robustly. So, look, this work came about from us questioning, whilst I was running research at the Defence Medical Rehab Centre, really questioning whether or not chronic exertional compartment syndrome existed. It was defined back in the mid-50s by a French group who really felt it bore some similarities with acute compartment syndrome, which we all know is a surgical emergency. But in reality, very little had been done in order to look at either the histopathology or the underlying mechanisms. But yet, we've got practitioners around the world describing patients as having chronic exertional compartment syndrome and therefore coming up with some either invasive or non-invasive methods to try to treat it. But I think we often have to question some of these diagnoses, and I personally don't believe it exists. I think it's a mistake. And so we went to do a little bit of research in that military group where we would be seeing 400 or 500 patients a year presenting with the condition, and started to make the assumption that actually if this wasn't pathology, what could it be? And that takes you to a typical overuse injury, the one that we see in typists or people who do a lot of manual work in terms of muscle overload. And really what I'm going to be talking about is actually how we went about that process and how we validated the data and what we felt you could do about it in changing that loading of the muscle patterns.
Excellent. Well, we'll look forward to hearing more about that at summer school. Now, another specialist area of yours, and certainly something you've lectured on, is return to play. So how has the use of 3D biomechanical analysis really sort of changed your approach to treating patients in recent years?
For sure, and look, I'm very fortunate. The Sports Surgery Clinic recruited me 3 years ago to set up a 3D biomechanics lab using Icon and AMTI technology, something that you would usually find as part of day-to-day research within a university department. And we've embedded that into clinical practice. We see 220 patients a day in rehab here. It's a big private hospital. But we've made 3D biomechanics part of our typical ACL and athletic groin pain rehab. And we've built a database of 2,000 or 3,000 patients. And what we started to learn is actually some of the existing methods of looking at biomechanical data are too laborious. And we need to start to look at the relationships between body segments rather than actually necessarily just the load at a joint. And what that's enabled us to do is start to group patients into different movement strategies, which we can use from a performance basis. We published some data last year looking at the performance requirements of change of direction of a 110-degree sporting cup maneuver. And actually that's really started us to aim, rather than restoring someone back to normal, in inverted commas, whatever normal is, to try to restore them faster and better at change of direction. Because really there is no accepted normal. We don't know whether variability is wide or narrow in that sort of group, or whether in fact there is a perfect movement. So rather than trying to aim for a target which we don't really understand what we're chasing, we're trying to identify the things that we can return to optimize performance and therefore make that change of direction faster, or that straight line speed, or the slide hurdle hop. And I'm going to talk through a lot of those tests and actually how we take some of the data and make it practical. Of course, not everyone has the benefit of a 3D lab, and what we're trying to do at the moment is use an inertial sensor system to create a field version of a lot of this data so that we can feed in some normal patients as well as injured patients. And hopefully we'll be able to give that a wider applicability so that without the technology, you'll be able to use that information to apply to your patients.
And finally, Andy, can I ask you for a quick top tip when we're treating a sports patient?
Look, I think it's actually getting specialist advice in strength and conditioning. One of the big changes I've made at the clinic here is to start to employ strength and conditioning coaches alongside our physiotherapists, podiatrists and physicians And I think adding that expertise in very skilled training of movement is something that we can all benefit from. And certainly, I think strength and conditioning coaches can complement practice, both commercially but also clinically.
Excellent. So we all need to work together a little bit more. Thank you very much for your time this morning, and we very much look forward to hearing you speak and seeing you at the summer school.
Pleasure. I'm looking forward to it.